A 30-year-old male presented with hemoptysis and right shoulder pain. I am showing you his chest radiograph. Describe the findings.
Let's see. Yes. The frontal chest radiograph demonstrates several well-defined soft tissue density nodules throughout both lungs with no zonal predominance. Crucially, the right humerus visible on the edge of the film is abnormal, demonstrating mottled sclerotic density and an apparent periosteal reaction. This bone lesion suggests an aggressive primary bone tumor.
Given these bone and pulmonary findings, what is your primary diagnosis?
Given the combination of multiple lung nodules and an aggressive humeral lesion, the primary diagnosis is lung metastases secondary to an underlying osteosarcoma.
I am displaying an AP radiograph of the patient's proximal right humerus. Describe the findings.
This AP radiograph of the right humerus demonstrates a pathological fracture of the upper diaphysis. There is an underlying poorly defined bone lesion in the metadiaphysis showing a wide zone of transition, mixed lytic and sclerotic areas, and an aggressive periosteal reaction, confirming a primary osteosarcoma.
What is your differential diagnosis for multiple pulmonary nodules?
The differential diagnosis for multiple lung nodules includes metastases and benign pulmonary arteriovenous malformations. Infectious causes include fungal granulomas, tuberculosis, septic emboli, and abscesses. Non-infectious causes include sarcoidosis, granulomatosis with polyangiitis, rheumatoid nodules, and amyloidosis.
I am showing you a chest radiograph from a different patient. What classic diagnostic pitfall does this illustrate, and how do we avoid it?
This chest radiograph from a patient with neurofibromatosis type 1 illustrates how cutaneous skin nodules can project over the lung fields and masquerade as pulmonary nodules. We must carefully verify whether nodules project outside the lung zones or extend into the subcutaneous tissues to avoid this pitfall.
What imaging clues can suggest the specific primary tumor of lung metastases?
Several imaging clues can point toward the underlying primary malignancy. For instance, metastases from squamous cell carcinomas, colorectal cancer, melanoma, osteosarcoma, and cervical cancer are more likely to cavitate. Conversely, metastases that calcify or ossify typically originate from osteosarcoma, breast, thyroid, testicular, or mucinous ovarian carcinomas.
How would you manage this patient as a radiologist?
I would compare the chest radiograph with previous films to assess nodule progression. I would communicate the findings of multiple pulmonary nodules and an aggressive bone lesion of the proximal humerus immediately to the referring clinician. I would recommend an urgent staging chest CT to evaluate pulmonary metastases, alongside a dedicated MRI of the right humerus for local tumor staging and to assess neurovascular involvement. A staging whole-body bone scan, or FDG PET-CT, should also be recommended to evaluate for skeletal metastases. I would refer the patient urgently to a specialized regional sarcoma multidisciplinary team, MDT, and orthopedic oncology. Importantly, I would advise that no biopsy of the bone lesion should be attempted locally. It must be planned and performed under image guidance at the specialized sarcoma center to ensure the biopsy tract can be safely resected during definitive limb salvage surgery.